ANITA trial is a randomized phase 3 placebo-controlled trial that was led by the GEICO group and the ENGOT group. It's an international study that explored the addition of atezolizumab to a standard combination of platinum-based chemotherapy followed by maintenance niraparib in patients with recurrent ovarian cancer and a treatment-free interval platinum longer than 6 months. The background of this study is that we have a strong rationale for combining PARP inhibitors and checkpoint inhibitors in ovarian cancer, but the contribution of this specific combination to the ovarian cancer was not known. We had data of the triplet combination in first line of bevacizumab plus checkpoint inhibitor plus PARP inhibitor that produced a benefit, but the individual contribution of this PARP inhibitor plus anti-PD-L1 was not well known. So we randomized 470 patients to standard chemo, followed by maintenance niraparib if the patient did not progress. That was the control arm, and in the experimental arm we had atezolizumab both in the chemotherapy phase and in the maintenance phase. Patients need to have up to 2 prior chemotherapy lines, the last one with platinum, treatment-free interval platinum longer than 6 months, and a mandatory biopsy before entering the study, because one of the stratification factors was PD-L1 positive. Well, the study included, as I said, 417 patients during a period of approximately 2 years and a half. The arms were well balanced. Most of the patients had only 1 prior line of chemotherapy. 14% had BRCA mutation, 1/3 had PD-L1 positive. Most of the patients, 2/3, had a treatment-free interval platinum longer than 1 year. In this case, the addition of atezolizumab did not improve significantly the median progression-free survival. The hazard ratio was 0.89, and we did not observe that those patients with PD-L1 positive tumors had an additional benefit of atezolizumab. We also look at the effect of atezolizumab only in the patients that started the maintenance phase. And we observed that a slightly separation of the curves with a hazard ratio of 0.8, but again was not statistically significant. In terms of safety, we have not observed new signals related to atezolizumab or niraparib. The safety profile was as expected. So what are the conclusions of this study? Well, the addition of anti-PD-L1 to PARP inhibitor and to chemotherapy in the relapse setting did not improve the progression-free survival, but this is a very important information to understand, to interpret the trials with checkpoint inhibitors in the first line, in which checkpoint inhibitors are combined with PARP inhibitors plus or minus bevacizumab, and it seems that for check inhibitor to work, it is needed also the anti-angiogenic agent on top of the PARP inhibitor plus the checkpoint inhibitor plus bevacizumab. Thank you very much.